Attendees are in listen-only mode.
Good afternoon and welcome to today's webinar. Welcome to the Leadership Development Group's webinar entitled The ACA Without the Individual Mandate, Medicare and Medicaid and Disruption in 2018, which is presented today by Dr. Kent Bottles. My name is Lisa Clark, and I am the Director of Operations and Coaching at the Leadership Development Group. Just a few quick notes before we get started. Please note that all attendees are automatically on mute for the duration of the webinar. Dr. Bottles will be taking questions in the middle of the presentation as well as at the conclusion. Please feel free to submit your queries via the questions box on your GoToWebinar control panel, and they will be presented to Dr. Bottles at the appropriate time. This webinar will be recorded, and we will be providing a link to the recording to all attendees. We appreciate your attendance, and we hope that you find this webinar valuable. We're going to give it probably another 5 seconds or so, and then I will turn it over to my colleague, Tracy Duberman, President and CEO of the Leadership Group, for a brief introduction. Tracy, you can go ahead.
Thank you, Lisa, and thank you to all of our attendees. For those of you that might be new to the Leadership Development Group, I'd like to take a few minutes just to introduce ourselves. We are a global healthcare talent development firm. We work with leaders and teams and the organizations that they serve across the health ecosystem, which includes providers, payers, and pharmaceutical companies. Our goal is to enhance leaders' ability to execute on their strategies. Kent, next slide. We build customized solutions with and for our clients, including results-oriented leadership assessment and coaching, high-performance team development initiatives, strategic succession planning programs, and executive, physician, dyad, and group leadership academies. Our academies are designed to empower leaders to take on the leadership challenges facing their organizations, their sectors, and the industry at large. Next slide, Kent. Great. So we have a worldwide faculty of over 200 organizational development practitioners, academicians, coaches, and consultants who have deep expertise across the health industry, which enables us to offer targeted insights and deliver impactful results. And we deliver those results to senior executives, physician and R&D, and other clinical leaders, teams, and boards. I'm very, very happy to introduce to you Kent today. This is a fourth webinar in a series that Kent has been providing for our clients and faculty on the changes that are occurring within the ACA and health reform and health financing reform. We're incredibly grateful to Kent for his expertise. Kent's ability to synthesize complex legislation and information into clear and concise concepts is a value add benefit to all of us working in the health ecosystem. And just by way of background, I know you can all read this slide, but highlights include that Kent is a founding TLD Group Advisory Board member for our academies, in particular our Physician Leadership Academy. And he has been instrumental in keeping us informed on key insights, trends, and development needs in the healthcare, insurance, and pharmaceutical marketplaces, which ensures that the work that we do is consistently evolving to meet the ever-changing needs of the industry and our clients. He is also a highly sought-out member of our Speakers Bureau. He presents on such hot topics as clinical integration, physician integration, policy and health reform, physician engagement, and accountability. And by way of background in terms of academically, he received his BA in history from the University of California, Berkeley, his MD from Case Western University School of Medicine, and he's board certified in anatomic pathology and cytopathology. And he's also a lecturer at the Jefferson University College of Population Health in Philadelphia as well, which I neglected to mention, but a very important part of his resume. So without further ado, I'd like to turn the mic over to you, Kent. Take it away.
Thank you so much, Tracy, and thanks to everybody at TLD Group that's been helping plan this webinar. What we want to do today is briefly talk about all the changes in healthcare in 2017, then talk about how the Affordable Care Act is going to probably survive in 2018, even though it'll be assaulted by the Trump administration, cover how Medicaid and Medicare is under threat, and then take some questions and make a pivot to talk about, will technology disrupt healthcare, and how will hospitals and primary care cope with such a disruption if it occurs? Healthcare was really, a lot of things happened in 2017. The GOP failed to replace and repeal the Affordable Care Act. However, a tax cut was passed, which repeals the individual mandate of the Affordable Care Act. The enrollment for the state marketplaces under the ACA was much more healthy for 2018 than we expected. CHIP was not reauthorized until late January 2018, which caused some problems for states. The Chronic Care Act passed the Senate. The drug opioid overdose epidemic caused decline in life expectancy in the United States for 2 years in a row. The natural disasters, the hurricanes and floods, put millions of people at risk for healthcare problems, and they're still at risk in some places. And then there was a lot of activity in the private merger deals that we'll talk about at the end of this talk that may disrupt hospitals. So the first polling question.
What was the biggest healthcare story of 2017? We'll give you a few seconds to answer. Okay, I'm going to close the poll and these are the results. 53% say that the GOP fails to repeal the ACA is the top story of 2017.
Great. So let's talk about the ACA. My prediction is that it will survive during 2018, even though the CRS payments, the individual mandate, and the Independent Payment Advisory Board have all been eliminated by the Trump administration. I think the ACA will survive in 2018, but we have to be aware that the Trump administration will do everything it can to diminish it without Congress actually having to repeal it because of fear of the November 2018 midterm elections. So Republicans have actually, at a retreat in White Sulphur Springs, West Virginia, just the beginning of this month, have decided that they're not going to go through reconciliation again in the Senate and try to repeal and replace the Affordable Care Act. As Senator John Thune, who's the third-ranking GOP senator, said it would be a heavy lift. We sort of tested the limits of what we can do in the Senate last year, and we're one vote down from where we were then. That refers to the Alabama special election where a Democrat was surprisingly elected to the Senate from Alabama. However, Paul Ryan at the same retreat has said that he really wants to push cuts to Social Security, Medicare, and Medicaid, but they want to kind of use better language. They want to talk about workplace development and helping people. Because as Mark Walker, one of the conservatives in the House, said, when we talk about Medicaid reform, that's not a great buzz phrase. Just recently, February 8th and 9th, in the early morning hours of February 9th, the Congress did pass and Trump did sign a spending bill. And it really is a hidden healthcare law in some ways. It's got some things the Democrats wanted and some things the Republicans wanted. The Republicans wanted to repeal the Independent Payment Advisory Board, which the Congressional Budget Office says will increase expenditures by $17.5 billion over 10 years. This was something that Obama and Peter Orszag, the architects of the ACA, really wanted to put in. It was to have an independent board that would allow cuts in Medicare to be made or changes in Medicare without Congress having to do it. it was so controversial that they never appointed the members of the board and never got functioning. One of the things the Democrats wanted was to fund community health centers for 2 years, and they also got $600 million extra for community health centers. The CHIP, the Children's Healthcare Initiative, was extended for another 4 years, over and above the 6 years. So now it's been extended for 10 years, which was a bipartisan thing. The Republicans wanted and did cut $1.35 billion in public health and prevention funding. There was $2 billion increase for the NIH and changes for Medicare Part D prescription drug donut hole, support for rural health and ambulances, and support for telemedicine and the Medicare Advantage. So this big spending bill, which is a big deal, has both a lot of things for the Pentagon, which the Republicans wanted, and you can see here a lot of things for healthcare and other domestic priorities that the Democrats wanted. When we talk about the Affordable Care Act, we have to remember how Americans are currently covered in 2018. About half of us get our insurance from where we work. About 20% get their insurance from Medicaid, about 14% from Medicare, and only about 7% of Americans get their insurance from the individual market, the non-group individual market. That's the ACA marketplaces in the individual states. Now, if you look at the numbers, that means about 156 million Americans have employer-based insurance. Over 74 million Americans now get their health care from Medicaid and CHIP, and recognize that more than 30 states expanded Medicaid under the Affordable Care Act. Medicare covers about 55 million people, and the non-group individual market is about 17.5 million. That's the Obamacare exchanges, the ACA exchanges. However, and that's where all the excitement is when people talk about people losing their coverage, people having too high a premium. But it's important to realize that not all 17 million people in the non-group individual market are affected the same way. About 11 million are really unaffected by premium increases because they're low income enough to get federal subsidies. It's about 6.7 million who are affected. And what that means is that they make too much money to qualify for the low income federal subsidies, and yet they're still in the individual market, and they're the ones that get hit the most with the huge premium increases that you see in the newspapers. So that would be like if you make a little bit more than $48,000 if you're an individual, or if you make a little bit more than $98,000 for a family of 4, then you don't qualify for a federal subsidy, but you still have to pay a lot of money for your insurance. Now, one of the things that surprised us in 2017 and early 2018 was the enrollment history of the Affordable Care Act. You can see here that on the left-hand side in 2014, about 8 million people signed up the first year it was available. Remember how bad the website was when they first rolled it out? A lot of problems with the website. But then you can see in 2015, 2016, and 2017, it kind of went up to about 12 million people enrolling in this individual market. Again, this is that 17.5 million people that are in the individual market. What's most surprising is 2018. So even though Trump was saying that Obamacare was dead, even though Paul Ryan was saying it was in a death spiral, even though many people thought it had been repealed, it hadn't. 11.8 million people signed up for the Affordable Care Act to be covered during 2018. This really means that you really can't say that the Affordable Care Act is dying or that people don't want it. And it's especially impressive when you look at all of the efforts by the HHS under the Trump administration to not really get people to enroll. Now, the reason this is so important is that, as you know, the risk pool for insurance gets worse if fewer people enroll. Because the most people that are going to enroll are people that are very sick, so they'll enroll. But if you don't have healthy people in a risk pool, then premiums have to go up. So what the Trump administration did, because they don't really support the ACA, after all, they spent most of 2017 trying to repeal it and replace it, they reduced the advertising budget from $100 million to $10 million. They reduced the enrollment period from 12 weeks to 6 weeks. They cut it in half. They shut down the enrollment website every Sunday. That had never been done before. And they reduced federal fundings for navigators to aid signups. In many states, navigators went out and tried to encourage people to sign up. So this 11.8 million people that signed up for the Affordable Care Act, even with all the uncertainty surrounding it, is quite impressive. Now, as you know, the ACA can be summarized in 4 words: no outcome, no income. So because of the increased spending on healthcare for the federal budget deficit, the federal government wants to hold accountable doctors and hospitals and other providers for clinical outcomes and to also decrease the cost of medicine. As part of this, there's lots of pilot programs trying to transition from fee-for-service payment programs to value-based payment programs. And remember that value is defined as decreasing per capita cost and increasing the quality of the care that Americans get. Now, I want to spend a little bit of time on Charles Gaba's Three-Legged Stool, because I think it's the best way to summarize the 2,700 pages of the ACA. And it also is a great way for us to visualize the changes that may occur as the Trump administration abandons the idea of repealing the Affordable Care Act, but will do everything it can in its power to diminish it. So again, this is from Charles Gaba. You can follow him on Twitter. I have his handle at the end where we have a list of references to keep track. He's also the blogs at acasignups.net. But the three-legged stool of the ACA is a way to understand how complicated the ACA is and also to understand what happens when you make changes to it. So the blue leg of the three-legged stool is what insurance companies have to do. It's the carrier responsibility or what the insurers need to do. That's the blue leg. The red leg of the stool is what patients or enrollees have to do, okay? And then the green leg of the stool is kind of the carrot and sticks of the government responsibility. So the idea of this three-legged stool is that this kitchen stool only doesn't wobble if you have legs of the stools that are equal in size and all the things that make up it. Now, as we go through this, let's just say off the top that two things have been changed here. The cost sharing reductions, which is part of that green leg. So the green leg, again, is the government responsibility. Those cost sharing reductions, which we'll talk about in a second, have been eliminated. These are payments from the federal government back to insurance companies to help low-income people with copays. Those were being paid by Trump on a month-to-month basis. They were part of the uncertainty in the enrollment for 2018. But in October, he cut those off. So that bottom part in the green leg, the cost-sharing reductions are gone for now. The other part that's gone because of the tax cut is that part in the red leg. So the red leg is what enrollees have to do. The shared responsibility individual mandate penalty. That's gone because it was eliminated in the tax cut bill. So you can kind of see that if you take out that portion of the green leg, the government responsibility, take out that portion of the individual mandate, which tries to make everybody have insurance so that the risk pool is broad and you have enough healthy people to pay for the people that are going to get sick over the year, you can see that the stool is going to wobble. Okay, so if you shorten any part, the stool wobbles. If you remove any of the legs, the whole stool collapses. So let's just take a second, because this is our summary of the Affordable Care Act, and talk about first the blue leg. So the blue leg are the insurance company responsibilities. The top part of the blue leg is guaranteed issue. So anyone in America under the ACA has to be allowed to buy any policy. You could no longer discriminate on patients with pre-existing conditions. The community rating is associated with the guaranteed issue, means you can no longer discriminate on patients on the basis of their medical conditions or their gender. And the only price variation that's allowed is by age, where they live, and whether they smoke. So that you can charge older people only 3 times more than younger people. In the past, that ratio was 5 to 1. Now, the other part of the blue leg is those essential health benefits. So one of the things the ACA did was said that any healthcare policy sold under the marketplaces had to have 10 essential health benefits. And those on the next slide are ambulatory patient services, emergency services, hospitalization, maternity and newborn care, labs, rehab, prescription drugs, mental health and substance abuse, preventative care, and pediatric services. Now, that's part of why the premiums can be so high, because the Affordable Care Act was trying to say we should only sell insurance that will really cover people when they get sick. The last part of the blue leg of the stool are the minimum AV percentages, which means the bronze plan would cover about 60% of expenses, a silver plan about 70%, a gold plan about 80%, and a platinum plan about 90%. So that's the blue leg of the three-legged stool. Now we know that if you only have that, what happens is it's unstable. You can't have a one-legged stool. And the reason we know that is that Washington State and New York had tried this out in the past, and it was really unstable when you had all these guarantees that you made health insurers provide, because what would happen, it'd be like if you had auto insurance and you didn't have to have it until you had an accident. That after you had an accident, you could then buy auto insurance and it would cover your accident. So that's the problem that you have if you only have the blue leg of the stool. So let's go on to the red leg of the stool. That's the enrollee responsibility. Enrollees have to, before the individual mandate was repealed, have to get health insurance, or else they pay a penalty on the taxes. Now, one of the problems with this individual mandate was that the penalty was so low that many people just ignored it. In places like Switzerland or Germany, where the individual mandate works, the penalty is high enough that everybody does buy insurance. Enrollees are responsible for paying their premiums. They're also responsible for getting their act together, and during the open enrollment period, which we see under Trump has been cut from 12 weeks to 6 weeks, they have to sign up during an open enrollment period. So the red leg of the stool are the enrollee responsibilities, and that's pretty clear. Now the green leg is the carrot and sticks responsibilities of the federal government. So what this said was that under the green leg, you'd have advanced premium tax credits. So those are subsidies to people who make 100% to 400% of the federal poverty level. I think we said that that'd be about $48,000 for one person and about $98,000 for a family of four. So if you have low income, you can get a subsidy that allows you to help pay for your health insurance. Now the cost sharing reductions were different. Those were actually trying to level the playing field, and those were trying to reimburse the insurance companies for payments from the federal government so that they could lower the co-pays for low-income people. Now, what we've said already is that the shared responsibility mandate penalty on the red leg has already been eliminated, and the cost-sharing reductions were stopped in October of 2017. So you can see that this stool is kind of going to wobble. Now, I want to make sure that we be fair here. To be honest, this three-legged stool wobbled even before Trump messed with it. It wobbled because it turned out the tax credits on the green part of the stool were not generous enough. If you earn just a little bit more than $48,000, you hit the subsidy cliff and your premiums were real high. And so that was a problem that probably, to make it work, they should have increased the subsidies, and they definitely should have increased the penalty of the shared responsibility mandate penalty on the red leg of the stool. So it was wobbling even as it was designed, but if you eliminate the individual mandate and eliminate the cost sharing reductions, it's certainly going to wobble quite a bit. Other people have said that it's kind of like Ginga, that it's so complicated that the things that you like about the Affordable Care Act, the fact that they can no longer discriminate against people by their gender, or if you have a pre-existing condition, they eliminated lifetime maximums. Those things we all like as consumers. We don't like the individual mandate, saying that they're going to penalize us if we don't get insurance. But they're saying that in this case, that the person is pulling out the individual mandate, and that kind of is a problem because that pays for the things we like. So it's kind of like the Ginga puzzle. So here's the three-legged stool again. We now need to remember that it's changed. The individual mandate on the red part of the stool is gone, and the cost-sharing reductions are gone. Now, we know that they're undermining the Affordable Care Act because they've cut off the cost-sharing reduction, the subsidies, they've defanged the individual mandate, they didn't keep the websites and outreach running smoothly, they're not taking actions to decrease gaming of the systems, they're cutting off fundings, and they also are allowing states to use discretion in defining those essential health benefits. Famously, they recently have changed it so contraception coverage is not nearly as robust as it was before the Trump administration took over. So we've said that they've taken out the individual mandate, so it's time for a moment of silence for a requiem for the individual mandate. Let's try to remember what it was. It was a Republican proposal that came about in the 1980s to be in contrast to President Clinton's approach to doing this. It was supposed to encourage individual responsibility. When Governor Romney included it in the Massachusetts health care bill that he passed in 2006, it helped the finances of that bill. Remember that Hillary Clinton adopted it in the 2008 presidential primaries. Barack Obama was actually ran against it in the 2008 primaries, but then when they put the Affordable Care Act together, looking at the numbers, he realized that the financing wouldn't work out unless you had a penalty to encourage people to get health care insurance, because you want that risk pool as broadly representative as possible of both healthy people and people that are going to get sick. The nonpartisan Congressional Budget Office estimates that 13 million Americans over 10 years will lose coverage with the repeal that was in the tax cut, and they estimate that premiums will rise about 10% with the repeal. Remember, the insurance companies don't have to sell insurance on the individual marketplaces, and that anytime there's uncertainty about this or about cost sharing reductions, their response is to raise premiums to try to cover themselves. So again, we're talking about the ACA, the three-legged stools, as it goes forward in 2018. It will not be repealed, but it's going to be nibbled at around the edges. They've already nibbled and taken away the individual mandate, and they've taken away the cost-sharing reductions. So these cost-sharing reductions are a little bit complicated, but let's not get too bogged down in the weeds. This money that's in the ACA law for the federal government to send money back to the insurers of Silver Plan members to decrease out-of-pocket costs for deductibles, copays, and coinsurance. It's about $7 billion a year and affects about 6 million people on the exchanges. So it's a fair amount of money. Now, the House Republicans years ago sued the Obama administration, saying that some of the language in the Affordable Care Act was a little fuzzy, and it wasn't clear that Congress had appropriated this money. Most people didn't think this suit would go anywhere. A federal district court surprisingly ruled in favor of the GOP. That judge, however, said you got to continue the payments from the federal government to the insurance companies until it's appealed. Obama appealed it. It never was heard by other courts, by higher courts, because what happened was Trump got elected. So as we said, the Congressional Budget Office has said that this makes insurance companies very nervous. They think premiums could go up as much as 20%. Trump paid it for a few months and then stopped paying it, and he thought that it was an insurance company bailout. Even if they end this subsidy, which they have, the insurers still have to pay the money to the enrollees. So the insurance companies are still out this money. And we can see here that premiums are supposed to go up according to the Congressional Budget Office. It's also supposed to increase the budget deficit by about $200 billion. A lot of people were against the Trump administration closing off these payments. Doctors, hospitals, insurers, consumer groups, the U.S. Chamber of Commerce all said they should continue to pay these subsidies. Now, this gets a little bit complicated, but let's just not get too worried about it. But there were unintended consequences. Because the federal subsidies for really low-income people are tied to the premiums that are charged, and because insurance companies jacked up the premiums a lot in anticipation of them losing these CSR payments, it turned out that in 2018, there was really good buys to have on the insurance exchanges, which may explain why so many people, 11.8 million people, signed up for them, even though there wasn't much advertising. So as we see here, in most counties in the United States, you could get a really good insurance policy, a bronze plan, and pay zero out of pocket. So the insurers promoted this zero premium opportunity, and that's one of the reasons why the enrollment for 2018 was so robust on the ACA individual markets in each state. Now here's an example of how this works. It's a little bit complicated, but bear with me. This is actually for a 40-year-old in Philadelphia, Pennsylvania, which you may not know is a Super Bowl winning city. were very excited about that. In 2017, this person in Philadelphia on the left-hand side of the bar graphs would have paid $184, would be the subsidies in the blue. So that's the subsidies for low-income people. And a person would have to pay for a bronze plan $120, or for a silver plan in 2017, $190, or for a gold plan, $295. But look what happened in 2018 when 11.8 million people signed up. The insurance companies jacked up the premiums from $184 to $408 on the right-hand bar graph, so 408, 408, 408. And because they jacked up these premium amount, it turned out the consumer share in the orange went way down. So you could actually get a low-cost bronze plan with zero money out of your own pocket, or get a gold plan for $132 out of your own pocket. So because of the way that the premiums are set, the way that the subsidies are tied to premiums of a silver plan, it turned out that even though those CSRs were not paid, because the insurance companies overreacted and raised premium rates, it turned out that if you were qualified for the low-income subsidies, you could get a really good deal on insurance, and that's why many people signed up. Okay, so we're still talking about the ACA going forward, weakened, but going forward in 2018. We now know the individual mandate's been taken out of the red leg, and the cost-sharing reductions have been taken out of the green leg of the stool. Now, the insurance companies have not just said, oh, that's fine, don't pay us some of the money that you're supposed to pay us that's in the law. So there's been a lot of lawsuits, and there's about $12.3 billion in unpaid risk corridor payments, and about $2 billion in this year in cost-sharing reduction payments. And one University of Michigan law professor has said, these civil litigation, these insurance companies suing the federal government, is really larger in sheer dollar amounts than almost any other civil suits that he's aware of. So we have the Land of Lincoln Mutual Health and MODA health plans are just now before the U.S. Court of Appeals saying, you got to pay us this money back because it's in the law. And the federal government's saying, no, we don't have to pay you the money back. Many of the main co-ops went under, other co-ops in other states went under because they weren't being paid the money that they thought they were due from the Affordable Care Act. So this is a little odd in the sense that the Republicans are usually very suspicious of the government and friendly to the healthcare industry. And if the courts agree with the Republicans, the insurers' willingness to participate in the marketplaces will be undermined, and there may be a chilling effect on the willingness of private industry to partner with federal government. And that's actually part of the infrastructure plan, or these private federal partnerships. And so some think that it's short-sighted for the Republicans to be playing games with the full faith and credit of the U.S. Stay tuned. We'll find out if the courts rule in favor of the federal government, or if they rule in favor of the insurance companies and make the federal government make good on what was in the law. Okay, so we've said that at a retreat in West Virginia, the Republicans and the leadership in the House and the Senate have said we don't have the votes to repeal and replace Obamacare in 2018. But they don't want to do nothing. They still want to change Medicaid. Now, Medicaid was expanded in 30 or 31 states under the Affordable Care Act. And Medicaid now covers, as we said, 20% of all Americans. So in the donut chart here, this is information we've already seen, but Medicaid and CHIP in the orange covers 20% of Americans. Medicare covers 14%. There's about 9% still uninsured. 49% of Americans get their insurance from their employer, and that non-group we've been talking about is the 7% we've been talking about. But Medicaid was expanded under the ACA in about 30 states, but it's become a very popular program because it covers so many Americans. Now, originally it was just supposed to be for low-income Americans and children and pregnant mothers, but now 3 out of 5 nursing home residents get their payments from Medicaid. 2 in 5 people with disabilities get Medicaid payments, 2 in 5 children under CHIP, and 1 in 2 low-income individuals. So the fact that it covers so many Americans makes it really, really hard to change it. But Seema Verma, who is the head of CMS in the Trump administration, has been giving indications, and now they're giving out waivers that they're saying we want the states to have more flexibility to control costs in Medicaid. And so there's these 1332 waivers. That 1332 just refers to a section of the Affordable Care Act. And the big thing that Seema Verma and the CMS are saying is that able-bodied Medicaid recipients should be in private insurance and not dependent on public assistance. They make the argument that it would be more compassionate, it would give them more dignity to let people work. And she has a quote from her saying, we've put more than 10 million, 12 million people into this Medicaid program where the doctors won't see them. The policies that are in the Medicaid program are not designed for an able-bodied individual. In the past, we've known that if you put more paperwork barriers in the way of people signing up, you can change the number of people that go on Medicaid. Now remember that Medicaid is part of the expenses are paid by the state and part of the expenses are paid by the federal government. So Washington State in 2003 had a budget deficit and they wanted to reduce the spending on Medicaid. So they said, we're going to require paperwork twice a year instead of once a year. And they cut down the Medicaid enrollees by 40,000. Now, Louisiana recently wanted to maximize the eligible children covered by Medicaid. So they simplified the sign-up process and they found that their cancellations fell by 20%. So if you want more people on Medicaid, you should simplify the paperwork requirements. If you want to cut Medicaid and cut budgets, both for the federal government and the states, you want to produce more paperwork. Now, Seema Verma is the head of CMS because she was an independent consultant who put together the Medicaid expansion program under Governor Mike Pence of Indiana when he was governor of Indiana. So they did expand Medicaid, but they did it with a lot of changes. And we now have, the biggest change they did was that she required the people on Medicaid to pay fees, fairly low fees if you were low income, but fees every month. And if you didn't pay your monthly fees into sort of an HSA, then you got locked out for 6 months and could get kicked off. But we now have results from her Indiana experience from 2015 to 2017, and they did indeed have 25,000 adults kicked off of Medicaid in Indiana because they didn't pay their fees, and 46,000 signed up but were denied coverage. Now, the academics that study Medicaid and the people that support Medicaid call this a big step backwards. The problem is that when people lose their coverage or get locked out, their health care needs don't go away. Fiscal hawks say, no, this is a good thing because we're cutting the cost of medical care for the state government. So what's been happening just recently at the end of January is that the Trump administration is approving a lot of these waivers so that different states can change their Medicaid programs. The biggest one that's happened is Kentucky. They are now putting a work requirement in that if you're able-bodied, you have to go to work. And we know that these administrative burdens reduce signups for pension plans, for food stamp programs, and turnout in elections. And the people that are against this kind of approach say, well, wait, the people that are low income have less stable work schedules, they don't have bank accounts, they have transportation difficulties, and some of them don't have access to the internet. So when you put these burdens on, it makes it really hard for them to comply and to get covered. So what Kentucky has applied for, and it's just been approved, is that a bunch of administrative rules. There'll be work requirements, there'll be monthly premiums to retain coverage so that you have to pay into an HSA. You have to notify the state every month if your income changes. There's a 6-month lockout if you don't renew on time. They're actually going to require a financial literacy course, and they believe that these obstacles give the beneficiaries more dignity. Critics of this approach have said that basically there's going to be so much new administration and bureaucracy that it's probably not going to save much money. Kentucky has about 1.3 million Medicaid recipients. It expanded under a Democratic governor, and then there was a change in the governorship to a Republican who is pushing this program. And the estimate is that about 100,000 fewer Kentuckians will be covered after 5 years of these changes. And again, the people that study this tend to be liberal academicians. Anytime the state requires more contact from the eligible population, you lose people at those places of contact. Without being tremendously well organized, it can be easy to fail. These sorts of barriers are ways in which humans get tripped up all the time when they're trying to do something that might benefit them. Now, other states are following suit. So there's 23 waivers that are pending last time I checked in 22 states. Indiana wants to have a separate fee for Medicaid enrollees who smoke. Arizona, Utah, and Kansas are trying to put lifetime caps on enrollment. So you could only be on Medicaid for 3 or 5 years. You couldn't be on it for more years than that. 10 states have requested a work requirement waiver similar to the one in Kentucky. Some states are trying to put in fees for emergency room visits. Other states are trying to say you have to have drug testing. And other states want to stop paying for the transportation of low-income people to their sites of medical care. So we expect that the HHS will be approving these waivers and Medicaid will be changed. So again, there's two ways to look at this. If you're a liberal who wants to have everybody covered by Medicaid or more people covered, you say things like, this is the untold story of the next chapter in the Trump administration's assault on health policy. It's a series of technocratic sounding changes that amounts to a slow bleeding of healthcare systems for low-income Americans, but it requires no act of Congress, and because it's so wonkish, never gets coverage in the media. If you're at the American Enterprise Institute and believe this is a good approach, you say there are people that are not going into the workplace, and we have a time when the economy is very strong. It's a good time to put work requirements in to get Medicaid. So polling question 2, I think, is about whether you think it's appropriate to have work requirements and other requirements for Medicaid.
We're just going to give it a couple of seconds, and we will close the poll. Okay. It appears that 60% of the people who responded believe that, yes, that is appropriate for work requirements and drug testing.
Okay, so we're still going forward, almost done with our wrap-up of the ACA for 2018, saying it's going to survive but be changed around the edges. This is one that we have to keep an eye on, but is less important than what we've talked about so far. In October of last year, Trump had an executive order where he asked the Labor, Health, and Treasury departments to submit ideas about how to allow association health plans to be sold across state lines and to expand HSAs and to allow short-term insurance projects. So what this is that some Republicans say, you know, those 10 essential health benefits that we have in the Affordable Care Act, they're nice, but they're so expensive. We should allow people to choose less expensive, less robust healthcare plans if they want to. And so this is something that Trump is saying, tell us how we could do this perhaps. We've had association health plans in the past, and the Labor Department has had problems with them because of unscrupulous promoters who sell the promise of inexpensive insurance but default on their obligations. So basically we've had in Washington State, there was an association health plan for 300 small employers. They charged $3 million in excessive fees and didn't have enough money to cover claims as they came in. There's a Florida case that left $3.6 million in unpaid claims. There's a New Jersey plan, of course it's New Jersey, that aggressively marketed but then didn't fund a plan that left $7 million in unpaid claims. So the problem with these plans is they're usually quite small, they don't have enough capital, and they've been in the past subject to corrupt people trying to use them to get money, but them not cover people when they need the coverage. So a Florida man was sentenced to 57 months in prison for embezzling $700,000 in premiums for an association health plan that covered churches. And one of my favorites, a Louisiana couple, was guilty of conspiracy by using the money that they got from a trade association plan to pay for spa treatments, diamond cufflinks, evening gowns, and foreign travel. Now, selling across state lines is something that Republicans have said that they really want to do, and they think it could be very helpful in lowering premiums. Most experts don't agree with them. The barriers to entry are not really regulatory, but they're financial and network development. And even the insurance companies have not been very much supportive of this plan. The idea here would be, I live in Pennsylvania. I think insurance in Delaware is cheaper than in Pennsylvania. So if I was able to go to Delaware and buy insurance, I could buy insurance cheaper. The problem is that there's different state regulations in Delaware and Pennsylvania, and the biggest problem is that most Delaware plans don't have Pennsylvania doctors. So the problem is that you could buy cheaper insurance if this went through, but then you wouldn't have any doctors to see or hospitals that are in network, and you'd have to go to the different state to get care. So one relatively bipartisan expert has said, I've tried for 10 years to explain this. It's a big problem. Just because a good affordable policy is available in another state doesn't mean I would be able to get the network of physicians and the good prices that are available in that other state. So we'll see. We'll have to keep track of that. Now, really, this just happened, and this is wild because Idaho is taking its clue from the messages coming out of the Trump administration, HHS, and they said, well, let's just allow health plans that don't meet the requirements of the ACA, even though it's still the law of the land. So in late January, the Idaho Department of Insurance said, you're going to be able to offer state-based plans that leave out the essential health benefits of the ACA. You can do medical underwriting, so charge more for people with pre-existing conditions. You can have dollar limits on total benefit payouts. And the state probably doesn't have the authority to do this. Some lawyers that have looked at this have said this is clearly flouting the ACA's insurance rules. This is definitely a Wild West strategy. These Idaho guidelines for health insurers are crazy pants illegal. That must be some sort of legal technical term I'm not used to. Crazy pants illegal. It's not even close, says Nicholas Bagley of the University of Michigan School of Law. Now, the first people that have looked at this said, I don't think insurance companies are going to do this because they're clearly opening themselves up to lawsuits if they follow this memorandum from the Idaho Insurance Commissioner. However, yesterday, Blue Cross Blue Shield of Idaho said they were going to do one of these plans. So this is probably going to result in lawsuits, and stay tuned. This is just probably the far end of how you can try to undermine the ACA. Now, Republicans want to change Medicare, but my prediction is that in 2018, they probably won't be able to weaken Medicare. Paul Ryan has said, made no bones about the fact that he would like to replace traditional Medicare with what he calls capped premium support, which would encourage seniors to purchase private healthcare insurance. Seema Verma, again, the head of CMS, which controls Medicare and Medicaid, wants the Innovation Center to give consumers incentives to be cost conscious. Medicare will run out of money in about 12 years. And so in the budgets that have been, the Trump budget that was just put out this week, and also in the GOP House budget, they talk about Medicare premium support plans. So in this, the government would pay a contribution. All seniors would get some money toward premiums, but they would like people to get their insurance from private insurers, not traditional Medicare. The problem with this would be that there's two crucial variables for premium support. How do you set the stipend levels to begin with, and how do you let those stipend levels grow over time? If the stipend levels grow more slowly than healthcare costs, then people will pay much more out of pocket to get coverage. If the stipend levels grows at the same rate as healthcare costs, then people will pay the same amount of money as they do now. But basically, they're saying we'd like to move people out of traditional Medicare into private Medicare Advantage. Nobody thinks that this is going to go through in 2018 because this would be very controversial, and most people in the Senate and in the House are looking toward the elections, the midterm elections that come up in 2018, and people are nervous that the House will lose its Republican majority and be taken over by Democrats. The Congressional Budget Office has looked at a variety of Medicare premium support plans and said that Medicare spending could fall as much as 9% or as little as 0.5% under these plans. Now, you have to take a look at the Trump budget. The White House budget was just revealed, and White House budgets don't really ever mean too much. They're really just sort of saying where the people would like to go. But if you look at the Trump budget that just came out this week, there's really big cuts to Medicare and Medicaid. So it's clear that the Republicans would like to even though they've raised the deficit with the tax cut, and they've raised the deficit with their spending bill that was just passed on February 9th, and they have an infrastructure program they'd like to put in that raises the deficits about 1.5 trillion. When you have big deficits, the biggest place you could cut would be Social Security, Medicare, and Medicaid. So some people are nervous that indeed that they would like to tackle those entitlements, and that gets people like the AARP, gets seniors upset about that. But this is a good place, I think, for us to stop and see if we have any questions from the audience before we make a pivot and talk about the disruption of healthcare that might occur because of all these mega mergers. Perhaps you've heard of CVS and Aetna and Amazon getting into healthcare. What does all that mean? So let's, the moderator, do we have any questions from the audience?
Yes, Ken, we do. We have a bunch of questions coming in. First question, what is the drop-off rate of coverage?
The drop-off rate of coverage, well, I'm not sure I understand. What does that mean?
That was the wording of the question, and it was sent early on in your slides. If that would help the question.
The drop-off
rate of coverage.
Sorry, I'm not tracking with that. Try another one.
Okay, so sure. So if the person who wrote that question could send me a little bit more context, I will ask that later on. Next question, how are providers changing their strategy in response to the slow castration of the ACA?
It's hard. I mean, I think uncertainty really causes difficulty for people planning. And as we're going to see, I don't think it's just the ACA. I think it's also disruptions that are going to come from private industry. But basically, what the health insurance companies are doing is whenever they get nervous, they raise premiums. I mean, that's the one thing that they do. Hospitals are getting upset because they're seeing their inpatient volumes decrease, and the last few years they've been trying to make that up on outpatient revenues. However, those look like those are declining as well, and so Moody's and other bond rating agencies have said it doesn't look good for hospitals or providers in the future. So I think what's happening is that most people believe that the transition from fee-for-service to value-based payments will continue, but many people are confused about how quickly that's going to happen. And so I think most of the people I talk to, both in hospitals, insurance companies, and medical groups, are just trying to stay viable until they can figure out where everything's going to end up in a value-based payment system. So it's a time of great uncertainty. I think there's a lot of anxiety out there. I think you continue to see private practitioners become employees of large integrated delivery systems. You continue to see a lot of consolidation of hospital systems, and some hospitals going out of business. So it's a bumpy ride. So I think all we can say is, and when we get to the end of the lecture, I think I'm going to give some suggestions on what providers and health plans can do. Next question.
Right. And Ken, I did get some clarification. It is, what is the drop-off rate of ACA coverage?
The drop-off rate of ACA coverage would be if people don't sign up because the premiums have gone so high and they don't qualify for the federal subsidies. So again, people that get federal subsidies that make $48,000 for a single person or $98,000 for a family of four, they're not having a drop-off in coverage. What they're having is good subsidies. What they may be talking about is the idea that with these waivers, that you might be able to have a state say, we don't have to cover maternity care, we don't have to cover contraception, we don't have to cover things. We don't really know how that drop-off is going to go because those waivers are still being applied for by the HHS. Now, what's interesting is that some states, mostly blue states, are actually in the process of trying to pass laws that would reinstate the individual mandate. So you see a lot of things happening right now in this chaotic area, with at one end of the spectrum, Idaho saying, we're going to allow all sorts of short-term, very cheap insurance plans that don't cover much, which probably are illegal and will not stand up in court. to then blue states saying, no, we're going to reinstate the 10 essential health benefits by state law in our state. So it's confusing, but we'll just have to wait and see how it shakes out.
Okay. We still have a bunch of questions coming in. Would you like some more?
I think we still have a little bit of time. Try another few questions.
Sure. If there is a Democratic wave, would it be easy to reverse course? Or is the damage done by GOP irreversible?
So many people believe, if you look at the results from the Alabama Senate race, from some results in New Jersey and Virginia, especially down ballot, there was just a Florida state Senate race that went Democratic that had gone for Trump. Many people believe that there's a good chance that the House of Representatives will change from majority GOP to majority Democrat. They have to get 24 seats to flip in order to do that. If that were to occur, I think that you would see a lot of things changing. However, how HHS interprets the law would still be under the Trump administration, and Seema Verma would still have the ability to approve all of these waivers. So I don't think that they could change any of the legs of the stool, but what they could change is interpretation of the 10 essential health benefits. They could continue to make different plans for Medicaid. They clearly would not be able to change Medicare if the House was controlled by Democrats. So I think that you'll still see a weakened ACA, but you would certainly not see any more of the Graham-Cassidy attempts to overturn the entire law. So big things would change. And the also thing that you'd see change, which would probably be very interesting and chaotic, would be if the Democrats control the House, then they would be able to have subpoena power to do a lot of investigations of various things that they think Trump is doing wrong. So I think you would still, even if the Democrats retake the House, the ACA will not go back to how it was originally designed, but then you might see some things that might pass to maybe perhaps reinstall the CSRs. Again, we'll just have to wait and see.
Okay. Another question?
Sure, one more.
You ready? Okay.
Sure.
Any insights into how likely the new HHS secretary will implement mandatory payment reform programs like bundles and/or global and downside risk for ACOs?
It's a great question. Azar is a much more traditional HHS kind of person. He's not a big fan of the ACA, but he served in HHS under one of the previous Bushes. And actually, Tom Daschle, who's a Democrat, used to be Democratic majority leader, is very high on him. So most people think that he's going to be more supportive of enforcing the ACA than Tom Price was, who, as you recall, had to resign over travel expenditures. So he's just started. And it's interesting, Azar just started. The day that he started was the day that Idaho announced these crazy plans to subvert the ACA law. I saw one quote by Azar, HHS Secretary Azar, who said, we have to go by the law of the land. So it'll be interesting to see if he tries to enforce the ACA and say, no, Idaho, you can't have those narrow plans that don't cover much. So most people think that he'll be more of a run-of-the-mill Republican HHS secretary and be a little less, he's not in favor of the ACA, but people think that he's going to enforce the law as it's written until if it's ever overturned. So maybe now is a good time to pivot and talk about, is healthcare ripe for disruption? Well, most people I talk to as I go around the country giving talks to lay audiences, hospital administrators, and physicians, most people don't think that healthcare is working very well in the United States. They think it's ripe for disruption. It's too expensive. The prices vary and are not related to underlying costs. There's no accountability for outcomes. Since the year 2000, inflation's increased 41%. Employer health benefit costs have gone up 191%. When you talk to employers, they really get upset about the fact that they increasingly in a global marketplace are having trouble competing with foreign companies because the foreign companies don't have to pay for healthcare. The healthcare is paid for by the government. We all know that we're the only industrialized country that doesn't have more or less universal healthcare. And we all know that the reason that employment is linked to healthcare is kind of a historic aberration after World War II, where GIs were coming back from the war and they still had price controls on because of the war. And so companies started offering healthcare as a way to attract workers when they couldn't increase wages. 62% of Yelp ratings for healthcare are 1 star, and 1 star is not good. I just saw, this is a recent article I saw in a Texas newspaper, and Ken Janda is a health plan CEO. So he runs a large health plan in Texas, but he recently has had to take care of his 90-year-old father who has unfortunately developed cancer and is going to MD Anderson, one of the better cancer clinics in the United States. And just trying to manage his father's care, he has said, quote, "Seeing the healthcare system up close from a patient's point of view has hit me. The system sucks." Again, sucks must be a technical term they teach in Masters of Public Health School. I'm not familiar with that term. So it looks like most people think that healthcare is ripe for disruption, and yet most people also say healthcare is never really, adopted IT in an early way. Healthcare is special. Healthcare can't be disrupted the way that Uber is disrupting taxis. So I think we're ready for polling question 3. Does the audience think that healthcare is ripe for disruption, and will it happen?
Okay, we'll give a couple more seconds for people to log in. Okay, I'm closing the poll. And it appears that 93% agree that healthcare is ripe for disruption.
Interesting. Maybe they're all going to buy stock in Amazon or CVS. So there's a lot of talk about this, and certainly people in healthcare equity deals believe that it is ripe for disruption and that money can be made. In 2012, there was only $277 million in healthcare equity deals. In 2017, there was $2.7 billion in healthcare equity deals. So a lot of companies, both startups and large companies, think that healthcare can be remade by developing new tools, digital tools, for consumers, patients, doctors, insurers, hospitals, health plans, medical researchers. Eric Topol, who is a cardiologist at the Scripps Clinic in La Jolla, and has written some influential books about the disruption of medicine and the digitalization of medicine, is quoted as saying, "There's no shortage of hype. We're in the early stages of learning these tools. Who do they help? Who do they not help? Who do they provide just angst, anxiety, and false positives?" So clearly there's a lot of, in the venture capital world, there's a lot of money pouring into companies that want to become the Uber for healthcare. Now, it's clear that healthcare cannot just keep adding employees while the volume of services goes down. We see the rest of the economy is producing the same volume of goods and services with millions of fewer workers, and yet recently healthcare systems are adding workers at a time of declining admissions and office visits. You just can't have that be sustainable. I mean, that just doesn't seem to work going forward. And this is a big deal because if you go around the country like I do, in many cases, in many towns, both small and large, the healthcare system is by far the largest employer. And so if you start to rationalize the number of employees, what does that do for the economy of that city, especially in rural areas? Well, who are the players? Who's trying to disrupt healthcare? I mean, just recently, in the last few weeks, there's been all sorts of excitement about that Amazon, Berkshire Hathaway, and JP Morgan Chase, 3 very large, influential, successful companies, have said they want to disrupt healthcare and start out with their over 1 million employees and the family members of those employees. Just before that announcement a few weeks ago, the big excitement was about CVS and Aetna, a so-called vertical integration between a company that has retail pharmacy, walk-in clinics, pharmacy benefit managers, and a large for-profit healthcare insurers. Humana and Kindred are coming together. Optum has bought the DaVita Medical Group. Cleveland Clinic is partnering with Oscar, which is run by Jared Kushner's brother and is an insurance company. Again, saying that different areas are being blended in the healthcare industry. Not-for-profit hospital systems like Intermountain and Ascension are coming together to try to manufacture generic drugs because they're upset that they believe generic drugs have been priced way too high and there's been shortages. Apple is certainly looking at consumer products. There's been some talk recently of putting all your healthcare data on your Apple Watch. Microsoft is looking at online storage and analytics services, and Alphabet, which is Google, is looking at all sorts of data business in the healthcare space. So traditionally, healthcare has been in distinct sectors of the economy. So there's been a care provision sector, which is doctors and hospitals and nurse practitioners. Insurance companies usually haven't gotten into too much of a providers, except for places like Geisinger and Kaiser. And then pharmaceutical manufacturing has been totally separate. But we're seeing that it looks like disruption may occur when these distinct sectors are increasingly becoming blurred. So let's just take a look at two of these options. One is the CVS-Aetna merger, which is undergoing Department of Justice scrutiny right now. So this would combine an outpatient care walk-in clinic, retail drug sales, pharmacy benefit management. Remember that CVS bought Caremark a while ago, and insurance. So those are different sectors that used to be distinct, but this vertical integration would combine those two companies in different industries. Well, if you convert the 10,000 pharmacy clinical locations that CVS has into community-based sites of care that are utilizing telephone conversations, retail clinics with advanced nurse practitioners, or apps on cell phones, you have a real potential to decrease cost. And you could have Aetna saying, hey, if you're an Aetna covered patient, you've either got to go to one of these places to get your primary care, or you go to this place and it would have a zero deductible, zero copay, or you go to a regular primary care provider and you might have a much higher copay. So Aetna would be able to guide people into using the primary care services that their same company provides. Now remember, when I was in Minneapolis running ICSI, I learned a lot about Target, which has walk-in clinics. And Target and CVS claim that they can make money on walk-in clinics by just breaking even. In many ways, it's just a lost leader, that because people come in and buy their drugs or their diapers or their bread or their meat at the CVS or their milk, that they really don't have to make a lot of money on providing health care. That makes it very difficult to compete against the CVS. CVS is very serious about becoming a healthcare company. In 2014, they discontinued tobacco sales, even though they were making millions of dollars on it. Recently, they've banned digitally altered photos on cosmetic products, saying that they don't want to body shame people by having digitally altered photoshopped people looking better than they really are. So the combination of the healthcare industry and retail savviness of CVS makes people think that this merger might really be quite successful. A lot of people are excited about Amazon, Berkshire Hathaway, and JP Morgan Chase. They've just recently announced the formation of an independent healthcare company. They believe they can use technology to provide simplified, high-quality, low-cost care for their employees and their families. Interestingly, they think that this will be free from profit-making incentives and constraints, which is strange to me because Amazon, Berkshire Hathaway, and JP Morgan have been most successful in the for-profit area. They combined have over 1 million employees, and that doesn't include the family members of those employees. So they have a fair number of patients that they could control. What would they do? They could clearly provide care through primary care gatekeepers, either family practitioners, internists, or nurse practitioners or PAs. They could have very narrow networks. They could have supply chain management, something Amazon's quite good at. They could have employee choice and risk sharing, and they've clearly indicated they want to use technology in new ways. One Harvard Business Review article's already come out and said, you know, Amazon's really good at one-click ordering, and boy, anybody that's had to go from different departments in a hospital and give their demographic data over and over again could see that that could improve administrative hassles and decrease overhead. Amazon has a frictionless commerce store where there are no cashiers, no money, all of the transactions are automatically taken off of your cell phone. That could certainly reduce hospital overhead. And clearly what they want to do is integrate data from health and purchasing to target specific patients with customized therapy. People think that Amazon bought Whole Foods mostly for the demographic data that you can get from a supermarket. And Amazon has been very willing to experiment and to have very low margins. So these folks think that they really might disrupt healthcare. Other folks, Eric Topol, who he says is a cardiologist who has written extensively on digital care, has said that, you know, Alexa could discuss symptoms, get feedback, and coordinate hospital post-op care. Other folks have said algorithms could be developed to identify patients that need the most care. You could build value-based insurance design plans. You could leverage telecommunication technology to deliver care to you anywhere. And you could eliminate the middleman like health plans and pharmacy benefit managers. When I talk to health plans and health insurers, they're very worried about collaborations like this could cut them out entirely of the equation and make healthcare insurance in a way obsolete. Now, some people are saying, well, wait a minute. Now, it sounds like that our audience thinks that, yeah, healthcare is going to be disrupted. These folks say, well, wait just a second, because Google and Microsoft have had major initiatives to influence the underlying healthcare delivery system, and so far they've failed. They also point out that healthcare is usually local. It's hard to prevent physicians and hospitals from raising prices and giving mediocre care, that you clearly need hospitals and physicians. The other thing that some folks are pointing out is that these three companies have no experience in healthcare whatsoever. Some people see that as a real positive, that you have to disrupt it from the outside. Other people think that that might be a negative. Other people point out that the actual employees of Amazon, Berkshire Hathaway's, and JP Morgan Chase are quite different. The demographics are JP Morgan Chase evidently has lots and lots of MBAs who are highly sophisticated. Berkshire Hathaway has everybody from realtors to people that sell See's candy. And Amazon has IT, artificial intelligence experts that are very sophisticated, and then $15 an hour warehouse workers. So that maybe that it would be hard to disrupt healthcare because the healthcare needs of the employees are so different. And other people talk about, well, classic disruption may not apply to healthcare because most disruption is with lower in value, lower in cost products, and some consumers don't want to settle for low value in healthcare. So Zach Cooper, who's at Yale and has written some interesting articles, says it's a bit like Mayo Clinic, Cleveland Clinic, and partners coming out and saying, we don't like our IT computers, so we're going to form a new IT company. And then Craig Garthwaite, who's a conservative economist at Northwestern, has said, I find it strange to see three firms that have critically depended on the profit motive to create value in their industries now seeming to believe they will motivate the various necessary actors by ignoring the profit incentives. So at this point in the talk, I've depressed myself so much, I think it's time for a little bit of humor. And so the Onion has weighed in. The Amazon warehouses are now stocked with 20,000 doctors in preparations for the new healthcare launch. They've also got 50,000 competitive price nurses, PAs, and pharmacists in their warehouses. You can have a 5% off your next purchase with a no rush option, and you get a prepaid UPS label to return your doctor or pharmacist if you're not satisfied. But online pre-ordering has been delayed after 4,000 general practitioners were crushed by a forklift accident. That's a joke. Just because it's not just healthcare delivery, Apple now has a research kit which is disrupting medical research. Stanford has recently enrolled over 54,000 patients in a heart patient study, and they're actually now trying to do some heart patient studies with using the Apple Watch app. And the dean of the Stanford Medical School has said, for us, this is a real eye-opener and going to really change the way we do medical research. Well, it sounds like that the audience believes disruption is going to happen. I'm not quite so sure, but what does that mean for us as providers? What should we be doing? Can hospitals respond to the chaos? It's clear that inpatient care is shrinking. Admissions by any measure have gone down. In one study, it was 12% in the last decade. A quarter of hospitals are facing inpatient operating losses. Most hospitals are trying to make up for hospital inpatient decreased revenues by getting more into outpatient things. And yet at the same time, you have these private investors funding independent diagnostic imaging labs, pathology labs, urgent care, dermatology practices, ambulatory surgeries, freestanding EDs, and they're all driving hospital margins down. Clinical innovations are driving hospital costs up. Hospitals can be odd man out in some of these recent mergers. And the hospitals are complaining that the regulatory climate is much more harsh for hospitals than for some of these disruptors. Lots of statistics saying that hospitals are looking at bad finances going forward. Moody's Investor Services just analyzed 150 systems and found that hospitals' median operating margins fell 3.4% in fiscal year 2015 to 2.7% in 2016. So really good hospitals are losing millions of dollars. Brigham and Women's Hospital in Massachusetts, one of the Harvard hospitals, recently had to decrease their workforce by 10%. In Massachusetts, there's actually a state law which is limiting the annual growth in healthcare to 3.6%, going down to 3.1% in 2018. So the state legislature itself is mandating that you can't make as much money in hospitals. And the CEO, in announcing their layoffs and buyouts, said our expenses continue to rise while constraints by government and payers are continuing to keep our revenues flat. MD Anderson, that famous hospital for cancer in Houston, had a 77% drop in adjusted income in 2016. They blamed most of it on a huge Epic electronic health record system. They had a 5% job reduction. The president of the system lost his job. So hospitals need to be asking a lot of questions. Is our market area going to have the population growth and economics and competition so as to continue to be a acute-centric enterprise? Does our public trust our organization for safety outcomes and convenience because of all the transparent metrics? Are we spending our capital and workplace priorities to invest in social programs that population health says will improve our community's health? What future state should we be? What are we doing today that we should not be doing tomorrow? What are we going to do if we're in a town that has CVS? What are we going to do? If we're in a town that Amazon or Berkshire Hathaway comes in and says, we can do primary care and just break even and make money, what does that do for our outpatient incomes? What other services can we provide so that we remain a trusted source of the needed healthcare in our community? I recently had a discussion with Al Bergner, a friend of mine, and he says that hospital leaders should go to work every day and answer these questions. What can our organization do to improve the quality, outcomes, and safety of the care we provide? What can we do to improve the efficiency and effectiveness of the clinical processes in order to lower the cost of care and be better stewards? What can we do to enhance the experiences of our patients and families when they seek out our services? What can we do to improve the health and well-being of the broader community we serve, whether that be a neighborhood, a city, or a state? What can we do to make our organization a more stimulating and vibrant environment for everyone who works here? So some people are saying, you know, hospitals need to at least think about disrupting their business model. Stuart Butler of the Brookings Institute has talked about that there's two ways to go. One is specialized focused factories, so that you'd maybe only do hernias or only do central nervous system or be a cancer center hospital. Others are saying that hospitals need to become hubs to support the social services to address the determinants of health that population health say is so essential for a hospital to stay valuable to its community. I recently wrote an article in Fierce Healthcare talking about that hospitals seem to be decentralizing care. So maybe a hospital has to become less of a hospital and more of a community resource that allows us to embrace the Healthy People 2020 program goals, to create links with other places, other community groups, to become a meeting place that's seamlessly integrated into the community, maybe becoming a repository to advise patients, especially elderly patients, about how to use digital services, AI, virtual technology, and certainly connect with diversified communities. Other folks are talking about that virtual health and remote monitoring will be increased as care migrates away from the hospital. People are now talking about community paramedicine, having EMTs go out and do a bunch of things in the home that used to be done in the hospital. In fact, I saw yesterday just an article that I just read about Brigham in Boston that is now having EMTs go out and prevent hospitalizations from all sorts of things that used to be in the hospital. There's now reimagined emergency departments that provide alternatives to inpatient hospital care. So these hubs that I've described have also been described by the Brookings Institute, that the hubs for healthy communities need to improve the collection, use, and sharing of data, make greater use of intermediaries, widen the skill sets of schools and hospital leaders, make the use of community obligations of nonprofit hospitals and financial institutions, as well as the community focus of the new educational statute to help launch creative partnerships, make greater use of waivers, demonstration projects, and other steps. So polling question 4, I think, is, should hospitals stay the course? Should hospitals become focused factories, or should hospitals become hubs to support population health? What do you think? Do we have the results of that polling question?
And it seems 96% believe that it should become hubs for population health.
Okay. Well, hospitals are not the only people that provide care. How about primary care? There's been some interesting attempts to disrupt primary care. Zappos, which is that shoe company in Las Vegas, the CEO of Zappos was in charge of a $350 million revitalization project in Las Vegas, and they had Turntable Health come in to disrupt primary care. And these folks did a wellness ecosystem, same-day visits, 24/7 doctor access by email, phone, and video, health coaches. They had 45-minute visits with a population health focus, prevention focus. Their financial model was $80 a month flat fee. Medically, this was a success. Financially, it was a flop. After 3 years, it had to close because they flatly refused to compromise when pressured by payers to offer fee-for-service options or to begin charging a copay. We firmly believe that healthcare is a relationship, not a transaction. Iora Health seems to be the most successful group of disrupted primary care clinics. They've now got 30 clinics in 11 metropolitan areas. They've been able to show a 35% to 40% drop in hospitalizations, a 12 to 15% drop in lower total healthcare costs. And interestingly enough, Amazon's just hired one of the medical directors from Iora Health in Seattle to be one of the people leading their Amazon, Berkshire Hathaway, JP Morgan Chase collaboration. One Medical is another group that's been pretty successful. They have 250 doctors in 40 cities coast to coast for a yearly fee of $149. Again, primary care is going to be very challenging if a lot of primary care gets shifted to CVS walk-in clinics or Target walk-in clinics or things like that. So we've had kind of a real whirlwind tour. The conclusions for 2018, it's going to be confusing, it's going to be complicated, it's going to be chaotic. The Affordable Care Act will continue to be the law of the land. However, the Affordable Care Act will be modified by these state waiver programs, by initiatives like the Idaho program, which I don't think is going to be able to go forward. But the Trump administration clearly will be allowing states to have much more flexibility in how they run their Medicaid programs. Uncertainty will continue. I think the transition from fee-for-service to value-based payment systems will continue. It may slow down a little bit. However, Azar, who's now taken over at HHS, I think is going to embrace these. And hospitals and physicians will continue to be threatened by private innovation activities and reimbursement declines. And I think it's going to be harder and harder for us to stay in business. If I had to have a bottom line, what should providers be doing? Somehow try to stay in business, keep your head above water. How are you going to compete with a successful CVS or Amazon? If you have CVS in your city, you better start be thinking about how you're going to compete. And then how are you going to change your business model? What are you going to be, a focus factory, a hub? What are you going to not do tomorrow? Are you going to embrace paramedicine like Brigham and Women's or like Geisinger and send EMTs out or fire people out to the home to do much more care in the home? The last slide I wanted to share was if you get tired of hearing me give these webinars, you can keep up like a pro just like me as long as you're willing not to have a life. The way I keep up is that there's 2 podcasts that are excellent. Julie Robner from the Kaiser Family Foundation and Dan Diamond from Politico. Vox.com and KaiserFamilyFoundation.org are fabulous websites for lots and lots of information. Commonwealth Fund has a lot of good information. The New York Times and the Wall Street Journal covers almost all of this stuff. The New York Times from a more liberal approach, the Wall Street Journal from a more conservative approach. I also get a lot of stuff off of Twitter. If you want to follow me on Twitter, I have lots and lots of links every day to white papers. Andy Slavik, who ran CMS under Obama, is a great person to follow. Lots and lots of stuff on Twitter. Charles Gaba is the person who invented the three-legged stool. You can follow him on Twitter, where I found it. Topher Spiro is another person who does a lot of healthcare blogging and tweeting. And if you're more of a conservative bent, Philip Klein and Avik Roy are 2 very smart conservative commentators who you can follow on Twitter and who can give you a nice balanced approach so that you don't become too liberal. With that, I think we have just a couple of minutes for a few more questions, and then we can wrap up at 1:30.
Terrific. Well, thank you, Kent, for such a comprehensive, thoughtful, and engaging presentation, as always. We received a lot more questions, and I just want to say quickly that we are going to respond to whatever questions we do not get to in the next 2 minutes via email when we send out the recorded webinar. So, Kent, the question I want to pose to you, what do you feel are the major impacts on pharmaceutical manufacturers of this change?
Boy, I think pharmaceutical manufacturers who have been under a lot of pressure all along are going to become under a lot more pressure. Let's just take the CVS Aetna kind of approach. If CVS and Aetna get together, then Aetna could say, let's make sure that we have by far the cheapest generic that can treat this kind of problem in our CVS walk-in clinic. And so you worry about that kind of thing would not allow pharmaceuticals to kind of introduce new and perhaps better drugs. I've been involved in some focus groups and talking to folks that run the formulary committees at large integrated delivery systems. In many cases, they're not really interested in talking about new drugs. They're more interested in decreasing the cost of their drugs by using generics, and they feel like they've already got good drugs on the formulary, and what they're mostly trying to do is get those drugs out to all of their patients. They're less interested in which statin they use than in using the cheapest one they can have that they can get out to all of their patients. I think if you look at the Kaiser experience in decreasing heart attacks and strokes, they believe it's more important to get a generic statin out there than talking about getting a new one that might be better. So I worry that the pharmaceutical industry is going to continue to have a lot of pressure, and they may get disrupted as much as hospitals, that their traditional business model may change. The other problem for pharmaceutical folks is, who is their customer? Is it the patient? Is it the formulary committee of the integrated delivery system? They have to really think twice, I think, that who is their ultimate customer as we continue to see pressure to decrease cost and increase the measurable quality of the care that we deliver. So unfortunately, I think that all of us need to be aware of disruption, and we don't want to end up like the executives at Kodak who were so embracing film that they forgot to figure out how to use digital technology. And near as I can tell, you can't get a roll of film developed anymore because all the pictures I see are digital. So we don't want to be that late adopter that says disruption is not going to happen, and then we get caught flat-footed. So with that kind of depressing conclusion, I think
yes, this comes to the close. Thank you, Kent. Really appreciate it. Thank you, everyone, for joining us.